And so welcome everyone. So this is our September 2024 webinar, and this webinar is mainly based on cavernomas, on which Dr. Chen will talk, and second will be on craniopharyngiomas management, on which Dr. Maruf will talk. So I welcome everyone and thank you, Professor Yuko Kato, for organizing this webinar, and I thank you, my colleagues, Dr. Raja and Dr. Liu, for conducting this, and Dr. Ashish for moderating, and my co-moderator, Dr. Hugh. And I would like to now Dr. Hugh to introduce our YNS speaker. Yeah, Dr. Hugh.
Dear Professor Kato and on the colleagues, today we have the first speaker is Dr. Masudovic. He is from Uzbekistan. He did his Bachelor of Medicine specialty general practitioner in Tashkent Medical Academy. And then he did clinical residency in neurosurgery at Republican Research Center of Neurosurgery in Tashkent, Uzbekistan. He is now working at Republican Research Center of Neurosurgery in Tashkent, Uzbekistan. He has involved and engaged in a lot of international educational and training activities, as well as have multiple publications in international journals. And he also a fellow at Fujita Health University. Welcome, Dr. Matmusayev for his talk on endoscopic extended transsphenoidal surgery for craniopharyngiomas. Please.
Maruf, we are seeing the other slide too.
Is it okay? Can you see my screen?
We are seeing the other slide also. Can you...
I think it's in a presentation mode. So
Just a minute. Can you see now?
Yeah, okay. Come back to the first slide. Okay.
Just a minute. Is it okay or?
No. You
No,
again.
previously was it.
It was previously working.
Okay. Sorry.
Okay.
Good afternoon, everyone. Thank you for invitation. I am very grateful for presentation today. My topic is endoscopic extended transsphenoidal surgery for craniopharyngiomas. So craniopharyngioma are challenging tumors which has tendency for tight adherence to surrounding structures and frequent recurrence. The extended endoscopic endonasal transsphenoidal approach has now become the first-line surgical approach for midline craniopharyngiomas. Due to limited surgical corridor, it is difficult to remove tumor behind the posterior clinoid process and dorsum cellar by extended transsphenoidal approach. The endoscopic extended transdorsum cellar approach with posterior clinoid ectomy offers more direct access, a wider surgical corridor without retraction of the brain, nerve, and vessels. However, some problems still exist. Postoperative endocrinological deterioration and postoperative CSF leak. Location of the craniopharyngioma. Craniopharyngioma usually located on the cellar, supracellular region, and the lateral extension to the sylvian fissure, and the third ventricle, and the extension to the prepontine or interpeduncular cisterns. Approach selection on the coronal plane. If the craniopharyngioma located midline within the ICA, and the sagittal plane intracellular, supracellular region, we choose transplanum transtuberculum approach. If the tumor located retrochiasm, third ventricle, and posterior fossa, we add the transdorsum cellular approach with posterior clinoidectomy. If the tumor with lateral extension, we use simultaneous combined transcranial transsphenoidal approach. So this is anatomical landmarks for planum transtuberculum approach. So bone usually opened like chef's head, and the medial optical carotid recess is the most important anatomical landmark for expanding surgical corridor. And usually we perform the linear dural incision. It is easy to close, so it can reduce the CSF leakage, but surgical window is small. For resolve this problem, usually we perform dural tenting for expanding surgical view. And for preservation of the pituitary function, it is important preserve superior hypophyseal arteries and their branches, perforated arteries. Even tiny vessels should preserve during the surgery. So preserving the superior hypophyseal artery, infundibular branch, and pituitary stalk can reduce the risk of panhypopituitarism. Skull-based reconstruction is one of the important things. So we should do carefully after tumor removal. So postoperative CSF leak is can lead to serious complications such as meningitis. Therefore, adequate skull-based reconstruction is utmost importance. For skull-based reconstruction, we use materials fat graft for small dural defect. For large dural defect, we use fascia graft with dural suturing techniques. So firstly, inlay we put fat graft or fascia graft and sutured inlay to the dura, and we use only another fat graft, and we put septal bone and rigid reconstruction with resorbable fixation mesh. This is a fascia patchwork technique for large dural defect after meningioma case. So usually we use double armored 6-0 Prolian, and both side planum sphenoidally dura threaded by needle and insert the fascia graft and continuously sutured from the at first from the right side to the bottom. So, like this. Bottom cellar floor from the right side. Then we started from the left side, continuous suturing. And at the bottom, not tightly tight. Then we put another fat graft online, and also we put absorbable plate for rigid reconstruction. So for small dural defect, we use the fat graft, two-piece fat graft. One is long shaped and another round shaped. Also, at the planum sphenoidal dura, threaded the Prolin suture, and also insert the long shaped fat graft. The dura and fat graft continuously sutured like the shoelace technique. So from the planum sphenidale to the cellar floor, we finish it, and another round-shaped fat graft inserted for eliminate the dead space, and also fix it, and to the bottom cellar floor dura, sutured and tightly tied. So among the 176 cases, postoperative CSF leak were observed in 3 cases. So case 1, 8 years old female, chief complaint with short stature, and patient has DI. Operative MRI demonstrates the suprasellar craniopharyngioma. Extended transsphenoidal surgery approach was performed. Right transseptal approach was performed, removing the rostrum of sphenoidale. After white sphenotomy, bone structure was confirmed and removed. So after opening the dura, we found the tumor, and arachnoid dissection was performed. For internal decompression, we aspirate the cyst component of the tumor. Then tumor feeders was found, was coagulated and cut. So tumor specimen was harvested, piecemeal removal tumor with a cup-shaped pituitary forceps, and also performing internal decompression, removing the calcified of the tumor. After adequate internal decompression, tumor was mobilized. So tumor SHA and branch dissecting carefully from the tumor capsule. So and also here we are dissecting the tumor from the perforators, optic chiasm, and tumor completely invaded to the pituitary stalk. And in this case, we cannot preserve the pituitary stalk. So tumor with pituitary stalk was cut and removed. And also here tumor attached to the tuber cinerum with the blunt and sharp dissection. This part also dissected and removed. Gross total resection was achieved. ICG confirmed good blood flow to the optic chiasm. Dura has closed by the shoelace technique, and so rigid reconstruction performed by absorbable plate. Post-operative MRI demonstrates the gross total resection of the tumor, and there are no any neurological complication and no CSF after surgery. This is another case, 56-year-old male with chief complaint is memory disturbance. So preoperative CT and MRI demonstrates the 48 millimeter cystic lesion with calcification in the suprasellar and prepontine region. So with the extended transplant transtuberculum approach, it's not enough remove the tumor the retrocellular area. So in this case, we use transdorsum cellular approach with posterior clinoidectomy. This is bone opening, and red line marks the dural opening. To prevent the post-operative CSF leakage, we planned open the dura in two-piece dural opening. For internal decompression, we planned the it was small incision on the clival dura for evacuating the cystic component for internal decompression and shrinkage the lateral compartment of the tumor. This is surgical video removing the cellular floor and removing the planum sphenidale tuberculum cella. So after that, we pituitary gland extradurally elevated, and the dorsum cella after drilling are mobilized and removed. Then posterior clinoidectomy was performed. So, and bleeding, venous bleeding stopped by using Surgicel. So a small incision performed on the clival dura, aspirated cystic component of the tumor, then opened the planum sphenidale dura. So tumor was found, and dissecting tumor from the pituitary stalk and from the optic chiasm, and tumor was mobilized and removed piece by piece. And here also we can see perforated arteries dissected from the tumor, and also here we're dissecting the tumor by sharp dissection from the PCOM perforators. And after adequate internal decompression and mobilization, supracellular part of the tumor was removed. For removing the retrocellular part tumor, small incision clival dura was extended, and also this area we removed the tumor capsule. After removing the tumor, we can see the neurovascular structures. Gross total resection achieved in this case after tumor removal, and dura closed by suturing, and we put only fat graft and also rigid reconstruction with the absorbable mesh. So post-operative course was uneventful. Gross total resection of the tumor was achieved with preservation of surrounding neurovascular structures. Cognitive function was improved immediately after surgery. And post-operative CT demonstrates the adequate bone removal from the planum sphenidal cellular floor, dorsum cella in the endoscopic and the nasal transplanum and transdorsum cella approach. Also, post-operative MRI demonstrated the gross total resection of the tumor. In conclusion, on the extended transsphenoidal surgery, there is no retraction of brain tissue, and the approach allows for wider visualization, potential to achieve less invasiveness with safe and radicality. Superior hypophyseal arteries should be preserved to protect visual and pituitary function. Adequate surgical corridor is essential to prevent postoperative complications. Adequate opening and closing of the skull base is essential for the extended transsphenoidal surgery. Thank you for your attention.
Thank you. Thank you for this wonderful talk. And so now I would like to invite Dr. Ashish for experience comments. Dr. Ashish.
Thank you, Dr. Ishu. Excellent talk, Dr. Maruf. I think some of the cases were really very challenging. With craniopharyngiomas, most of I think, even it depends on where you are, but there is an equal divide from open surgery and endoscopic surgery, like between as an option for surgical resection. I think a lot of faculty, they think there is a high risk of meningitis because of CSF leaks, and that's why they do not attempt craniopharyngioma through nose endoscopic route. But I think your dual closure techniques are very clear and very definitive. I just wanted to ask if what are your CSF leak rates in your own practice or in your own center? Like how many patients usually still, even after these kind of very nice closure techniques, experience CSF leak, and if you use like lumbar drain to further reduce the chances?
This case at the Nagoya University during my fellowship, I studied. So they reported cases in 176 cases totally, including the standard transsphenoidal approach and also extended approach. They have only 3 cases after surgery with dural suturing. And for CSF leak patients, for second surgery, they used lumbar drainage or nasoseptal flap. So they used very rarely nasoseptal flap, only when the recurrent case or if the patients planned radiotherapy, they used nasoseptal flap.
Yeah, I think it's very important to know the pre-op imaging very well, because if suppose you have a calcified and ossified component, which is closer to the sella, then it becomes difficult to approach through the endoscopic route. But I think now surgeons, are even attempting that kind of tumors. But consistency and how it looks on the MRI, what is the T2 weighted, appearance, pre-op CT also important, is helps to see whether you have a solid component which is more closer to you, and if it is completely ossified versus calcified, because then if it's calcified and it's close to ICA, then risk of vascular injury also is there. But I think have you seen in those 176 cases, or even further cases, like how did you decide the cranial versus transcranial versus endoscopic approach based on what criteria, for example?
You mean when you use transcranial or
Yes, yes. What were the cases where they use transcranial approaches, for example?
For midline craniopharyngiomas, they always use transsphenoidal approach, except pediatric patients from the 4 years age, they use transsphenoidal approach. If the tumor craniopharyngioma extended laterally, they choose combined approach or two-stage surgery, maybe at first transsphenoidal approach and second stage transcranial approach. Also, it depends hospital and surgeon's preference. So I saw 2 cases of combined approach when the tumor laterally extended. We use eyebrow supraorbital keyhole approach and transsphenoidal approach.
Thank you so much.
Thank you. Thank you for your comments.
We have Dr. Chen, and welcome Dr. Chen for joining the webinar.
Thank you very much. Sorry for the delay. I got some technical issue. I just log in and I'm looking for the share screen button for this.
Yeah, Professor, give us some time. There is ongoing discussion. And yeah.
I got no.
Before that, maybe Dr. Ben.
Yeah, Dr. Ben, please ask your question.
Yeah, and first of all, thank you, Professor Chen, for joining. So, but maybe shall I ask a question to Dr. Maruf concerning his presentation first? And thank you, Professor, thank you, Dr. Maruf, for these excellent cases and bringing up the endoscopic approach to craniopharyngioma. And this is a very important topic and very small technical tips that I would like to ask about your team experience. First, concerning the posterior crinoidectomy. So what kind of approach do you use? Do you use extradural or interdural approach to the posterior canal during? And how would you find the advantage of this technique? And because sometimes I think that interdural during may achieve a more complete during for the posterior canal process. So and my second question is about, do you have experience for some cystic craniopharyngioma with attachment to the third ventricle? Because most of the times we could, following the path of the craniopharyngioma, we could open into third ventricle. And the problem is not with the visualization. The problem is the decision of how much you remove. So do you try to peel the cyst wall from the hypothalamus? So because you know that you try to achieve the complete removal. So sometimes the main difficulty would be the cyst wall. So how would you approach this? So also I would also congratulate your team's result and very excellent techniques in repairing the high flow CSF leak. So also in our center, we try to achieve with dual gen abdominal fat graft with nasoseptal fat. Usually in our experience, the leak rate is more than 5%. So yeah, so these are the questions, and I would like to hear about your opinion about this. Thank you so much.
Thank you for the question. For posterior clinoidectomy, the department they use extradural posterior clinoidectomy, so they consider it's more safe and can be prevent the pituitary function. If we perform the intradural posterior clinoidectomy, we need to the pituitary gland mobilization transposition or sacrifice the inferior hypophyseal artery. Some reports showed that after the surgery, we can observe the hypopituitarism, like this complications. So in our department, they prefer extradural posterior clinoidectomy.
Yes, my second question is about the cyst wall. How do you manage if it's adherent to the hypothalamus?
Hypothalamus.
Yeah.
If the tumor strong adherent to the hypothalamus, we remove as much as possible, and to prevent the damage of the hypothalamus, we leave this part tumor and we observe the patients. If there are progression of tumor, we'll recommend radio surgery.
Yes, thank you so much.
Can I answer your second question?
Yeah, you answer it. Yeah, very good. And really enjoy seeing the video and very nice video.
Thank you.
So, do we have any discussion or Dr. Yasin?
Today we have a two lady neurosurgeon from Bangladesh.
Yeah,
So
Professor.
maybe remote.
Yes.
Yeah, some question. Please don't hesitate.
Yes. Thank you for a very beautiful presentation of 76 cases of your demonstration of craniopharyngioma. We usually faced in our postoperative cases electrolyte imbalance. So how many of your cases you have faced electrolyte imbalances in craniopharyngioma?
Sorry, can you repeat your question? You mean syndrome inoperated?
Yes.
Diabetes insipidus.
I cannot remember exactly number of patients, or after surgery, some of patients suffered with this syndrome. So they every day check the blood to the electrolytes and manage with water intake. I forgot on exactly number these complications.
Okay, thank you very much.
Jasmine?
Yeah. Thank you. I really appreciate your suturing technique during reconstruction of the cellar floor. So I have one question that in your first case, you have shown that there is dense adhesion between the tumor and the pituitary stalk. You have shown that. And despite of having this adhesion, you have totally removed the tumor. That is gross total resection done. So why did you go for gross total resection? Whether there is dense adhesion between the tumor and the pituitary stalk, and rather you can prefer near total resection for this case. And what is your postoperative outcome? And is there any features of hypopituitarism postoperatively?
Yes.
Case one.
Yes. In case one, pre-operatively, the patient suffered hypopituitarism and DI, and during the surgery, we found the tumor invited to the pituitary stalk. To achieve gross total resection, we sacrifice the pituitary stalk. So if the some surgeons prefer sacrifice stalk to achieve the gross total resection. Some surgeons, as you say, prefer subtotal resection with radiotherapy. In our department, it's my teacher usually tried to achieve the gross total resection. If we preserve the pituitary stalk, the patients, we cannot solve the GI. After surgery, also the patient will have GI and hypopituitarism. That's why we didn't try to preserve the pituitary stalk.
Okay. So that is your preference in your department.
Yes, and some literature papers recommended if that CASAM type 2, it is they also reported it's impossible to preserve the pituitary stalk, and some surgeons recommended if the patients before surgery already have like GI or panhypopituitarism, we can cut the stalk to achieve the gross total resection and reduce the chance of recurrence of the tumor.
Thank you very much.
I think in these cases, it's very important to know that for young neurosurgeons, especially, that the amount of handling and the consistency of tumor varies from each case to case. Sometimes it's invading important structures. Then surgeons do not want too much of hypothalamic damage or perforator injury or any traction on the optic chiasm. In that case, they will be a little less aggressive and more conservative. And also depends on how thick the tumor is, or how firm it is, or is it soft and is it cystic. There are a lot of adjunct techniques which have been used, like as Dr. Maruf said, radiosurgery, radiation, chemotherapy, bleomycin injections if there's a focal cystic areas of tumor recurrence. Craniopharyngioma is something which is known for its recurrences, especially in kids. So, like, most of the surgeons are aggressive, and if they've removed everything, if it is stuck to the pituitary stalk, they'll try to remove that as well, because if you leave a little bit behind, then it has a high chance of recurrence. And most of these patients, as Dr. Maruf said, they have hypopituitarism to start with, so they will anyway need lifelong hormonal therapy. So those are the few things which are probably quite nuanced in craniopharyngioma surgeries.
Sure.
Yeah, sure. Are there any more questions? So thank you for the wonderful talk, Dr. Maruf. And now we'll proceed to our next speaker, our main speaker, Dr. Chen. So I would like to invite our next speaker, who is currently Director of Intraoperative MRI in Neurosurgery, PLA Hospital, Beijing. And he has been interested in managing the epilepsy surgery and doing cavernomas. And today his topic will be on cavernomas. He has published more than 10 papers in various international journals. And today he will be talking on pure ventriculoscopic approach in managing thalamic and brainstem cavernomas, a technical note. And I would like to invite Dr. Chen to present his presentation. Please, sir.
Well, dear Chairman, dear Professor Kato, today it is truly my honor to be here and share with you, our experiences for the pure ventriculoscopic resection of the brainstem and thalamus cavernomas, cavernous malformations. Let me share my screen. Well, it's a little bit slow. Well, sorry for the delay. I got some technical problem with the logging the Zoom. Okay, can you see the slides?
Yeah.
Okay. So as we know, the brainstem cavernous malformations, aka CMs, account for 20% of the intracranial cavernous malformations, and brainstem CMs remains the surgery to the brainstem cavernomas remains challenging for neurosurgeons, and however. The brainstem cavernomas have significantly higher annual bleeding rates if we compare it with other intracranial cavernomas. For example, if we consider the annual bleeding rate, the brainstem cavernomas without a history of hemorrhage, the bleeding rate is about 2.8%. However, if a brainstem cavernoma case with previous hemorrhage episodes, the bleeding rate will be as high as 32.3%, which is quite high. But if we consider the other intracranial cavernomas, without previous hemorrhage, the bleeding rate is sorry, that's should be with only the 0.3%, while with previous hemorrhage, the bleeding rate will be as high as 6.3%. So from this statistics, we can see the brainstem cavernomas has a significantly higher bleeding rate if the patient got previous hemorrhage episode. So we usually consider we should be more aggressive for the surgical treatment or removal of the brainstem cavernomas because because the brainstem is full of the eloquent structures. If the cavernoma has a hemorrhage, it will be a more catastrophic scenario for the patient. So we should be aggressive, more aggressive, but because the surgery of the brainstem is still very challenging and has a very high risk. So usually we are, from this aspect, we are more conservative if we consider the surgery to the brainstem, if we compare to the other intracranial locations. So how can we handle this? And can we have less invasive way of surgery than the conventional microscopic surgery? We consider the ventriculoscopic or endoscopic surgery for selected cases of the brainstem cavernomas. For example, this case, this is a 7-year-old female, a 7-year-old girl suffered from repeated headache and vomiting. The patient has got the previously hemorrhage. Although the hemorrhage is the hematoma is very small, but it still got very symptomatic, and the patient also suffered from the hydrocephalus. And we can see there's a small lesion located in the midbrain and located just blocking the aqueduct opening. So from the sagittal view, you can see here there's a popcorn-like image, a lesion obstructed the aqueduct opening right here, located at the top of the midbrain. So that possibly may be a midbrain cavernoma with obstructive hydrocephalus. The patient got hydrocephalus and enlargement of the lateral ventricle, which offered us a safe corridor for the endoscopic surgery to access the lesion. So, sorry, sorry, I will play this. Sorry, the video is too big to be transferred from the network. So I will play this video separately. Okay. Okay, now we can see we choose a frontal approach. We inserted one standard ventriculoscope with a diameter of 6 millimeter. So we can access the lateral ventricle, the patient's lateral ventricle, with only a burr hole with a diameter of 8 millimeter. So we check the aqueduct opening. We can see the cavernoma here. It's a mulberry-like lesion and completely obstructed the opening of the aqueduct. Now, here's the anterior part of the floor of the third ventricle. You can see the mammillary body. So we use the contact laser to do the endoscopic third ventricular ostomy to relieve the hydrocephalus. So with a contact laser probe, we can just vaporize and perform the fenestration of the floor of the third ventricle. Okay, so that's complete. That's when we completed the ETV, the endoscopic third ventricular ostomy. Then we tilt the ventriculoscope to posteriorly to the aqueduct opening to access cavernoma. So that's our first mission, which was completely accomplished. Then we tried to access cavernoma with ventriculoscope. So here's the lesion here, right? You can see that the lesion is just located at the top of the midbrain and has got some mulberry-like appearance. Now we use contact laser to first try to vaporize and to resect some part of the lesion. So with the contact laser, it is quite straightforward and easy to do the job, because when we use the laser, we can perform the coagulation and vaporization and the resection of the lesion at the same time, right? So you see, the laser just coagulates and vaporize the lesion. Okay, after the coagulation of the lesion, we can try to resect the lesion through the instrument's channel of the ventriculoscope. Okay, that's a biopsy forceps. Okay, we just resect the cavernoma in a piecemeal fashion. Here's a midbrain. Here's some drainage wing, right? Okay, after we coagulate the surrounding of the cavernoma, we can try to perform the further resection of the cavernoma. Okay, so it is easy when after we we perform the hemostasis with contact laser. So now here you see, after the removal of this part of the lesion, we opened the aqueduct. Okay, another advantage for the pure ventriculoscopic resection of the cavernoma is, when we perform the resection, we can continuously perform irrigation through the channel of the ventriculoscope to prevent the collapse of the ventricle wall, right? So to maintain a clear view of the surgical field, right? So you see, now we can easily remove the lesion with midbrain intact, right? You see, here's some small residue of the lesion. We just remove it one by one. And for some bleeding, so for some mild bleeding, we can use a contact laser or the irrigation, just simply irrigation to stop the bleeding. So you see, after the resection, the aqueduct was in a very good shape, and the midbrain intact, right? So after the operation, the kids was the post-operative course was uneventful, and the kid has got no neurological deficit. So this is a follow-up image. You can see the ETV is patent, and the midbrain, the aqueduct is also we confirmed the patency of the aqueduct. So the patient got no neurological deficit. The eye movements was intact and all doing well. When the discharge after 1 week after the surgery, you can see we use only very small incision here, right? And a single burr hole and to finish the job. The second case is a 42-year-old male. He suffered from double vision for 3 months, and actually for 15 years and 3 months, right? Because he was diagnosed with midbrain cavernoma 15 years ago, but because he's afraid of the risk of the open surgery, so he chose the radio surgery, actually X-knife for therapy for the cavernoma, but it doesn't work. The double vision worsened in the 3 months before the admission. So he asked us if we can perform the minimally invasive surgery for this cavernoma. And you see, this case is a little bit more difficult than the last case because the cavernoma is located here. It's not at top of the midbrain, but a little bit lower here, right? So we still consider that we can use it is possible for us to do the endoscopic procedure for the cavernoma removal, but this time we cannot simply use rigid endoscope or ventriculoscope to do the job, because if we coming from the frontal horn, the rigid scope cannot access this part. So in this case, we need to combine the rigid scope with the flexoscope. So our plan was like this. We will use ventriculoscope, which is a rigid scope, plus flexible videoscope and contact laser to do the removal of the cavernoma. So the plan is like this. First, we use a rigid scope coming from this direction, and to do the ETV first to relieve the hydrocephalus. And then we use a flexible videoscope to pass through the aqueduct to access the cavernoma, and use a contact laser probe, which is also flexible, through the flexible videoscope to access the cavernoma and perform the resection. So that's our plan. So the positioning and the incision is like this, just a very small incision at the right front part. The length of the incision is 3 centimeters. With a single burr hole, we first extended the rigid scope to the third ventricle and performed the ETV. And then we use a flexible videoscope. That's a view under the with the videoscope. We can clearly see a mulberry-like lesion located at the midbrain and completely blocking the aqueduct. So that's cavernoma. And then we use a contact laser to do the removal of the cavernoma. After the removal, of the cavernoma, we keep the aqueduct patency, which is finish the aqueduct plastic, and then we use the flexoscope to passing through the aqueduct to the fourth ventricle until we reach the foramen of Machanti and check the complete patency of the whole CSF circulation. So this is video again. Cannot play. I will give you this video. Anyway, cannot play. Oh, sorry. Sorry, this cannot be played. Anyway, we successfully removed this cavernoma. You can check this. The postoperative course of this patient is also uneventful. The patient double vision relieved. And you can see from the follow-up image, you can see first the ETV is patent, and the lesion was completely removed from the midbrain. This is a preoperative MRI image. This is a postoperative image. The aqueduct is patent, and the lesion has already been completely removed. This is an image of the patient at the 1 month follow-up. You can see the eyes movement was intact, was completely normal. Case 3 is a 58-year-old male, suffered from headache and vomiting. Actually, the patient got several times of this kind of ictus. We scanned the patient with a MRI. You can see the patient got a small lesion here, located at the pons and very close to the surface of the fourth ventricle. And if we scan the patient furtherly, we scan the patient with the SWI MRI sequence. We found several lesions. However, this one, the lesion, which is very close to the floor of the fourth ventricle, is the biggest one. So we consider this one to be the one got several times of the hemorrhage, and which should be taken care of, right? So for this case, if we use the conventional microscopic surgery, we can technically access this lesion, but it's not very beneficial for the patient because a high risk and the high risk of the approach and the surgery itself. So we think that is it possible that we use the ventriculoscope to pass through the foramen of Machanti posteriorly to access the fourth ventricle and to remove the CM with the ventriculoscope, right? Is that possible? We think it is technically feasible for us to do that. So we tried like this. This is incision of this. We make a little bit bigger incision than the conventional conventional ventriculoscopic incision, because if the ventriculoscopic surgery is not possible, we can easily convert it into a standard microsurgical approach, right? So for the dura incision, it is very small, just like a 1 centimeter or 2 centimeters incision, and we inserted one ventriculoscope from the foramen of Machanti posteriorly. The diameter of the ventriculoscope is only 6 millimeter, So I truly wanna show you this this video, which is very interesting. Okay. First, after we inserted this is aqueduct opening. However, this is an inferior one, right? After we inserted the ventriculoscope into the fourth ventricle, we found this one, right? A part located in the fourth ventricle with hemosiderin deposit. And also, we use electromagnetic navigation to guide us to the lesion. This one is just the location of the cavernoma. So we use a contact laser again to do the coagulation and vaporize the lesion at this site, right? So after the hemostasis and the primary vaporization of the lesion, we start to remove the cavernoma with biopsy forceps. So for the residual, we use the contact laser. So in this piecemeal fashion, we completely removed this cavernoma. So you see after the removal, you can see the brainstem, the pons tissue here. So this was after the complete removal of the lesion. So after the removal, we just simply retrieve the ventriculoscope. So this image was captured by the ventriculoscope through the foramen of Marchanti. You see the opening of the aqueduct, inferior opening of the aqueduct was here. And this is the floor of the fourth ventricle. This is pons and the previous location of the lesion here. This is this is pica here, right? So this is a choroid plexus in the fourth ventricle. Very nice view with ventriculoscope. We can have very clear view because we have continuous irrigation, and to prevent also we can prevent the collapse of the fourth ventricle with this technique, right? So it's very simple and very safe. So after the surgery, this is a follow-up. The lesion has already been confirmed to be completely removed. This is SWI, only some hemosiderin deposit found here. So the patient post-operative course was uneventful. The patient got no neurological deficit and was discharged just 7 days after the surgery. So if we consider this from this aspect, we can completely beneficial from this case with ventriculoscopic surgery. So for thalamus, or for this patient was suffered from the thalamus and neighboring cavernoma. Again, sorry, I will give you the video here. So from the foramen of Monroe, this is kind of the lesion, this big CM was just viewed from the foramen of Monroe. In this case, we use a frontal approach with a ventriculoscope and with a single burr hole with a diameter of only 8 millimeter. So we use this kind of a micro endoscopic biopsy, not biopsy, bipolar forceps to do the hemostasis of the cavernoma. And after the hemostasis and coagulation of the surrounding tissue of the cavernoma, we try to remove the cavernoma with biopsy forceps in a piecemeal fashion again. So it just simply piece by piece remove this cavernoma until the complete removal of the cavernoma. So this is after the removal. You can see the lesion bed here. This is the last part of the lesion. Because it is too big, so we have to retrieve this part with lens through the endoscopic sheaths here, right? So in this case, we can try to remove bigger lesion with this technique. Okay, so so for summary, although so far we only have very limited experiences for 6 cases with this technique, which is we call it the pure ventriculoscopic resection for the cavernoma located in the thalamus and the brainstem. But so we has already proved that it is technically feasible for selected cases. And it's minimally invasive to the surrounding brainstem tissues. And the indications, so why we call it, we only can apply this technique for selected cases because we think the indications are as follows. First, for the midbrain cavernomas near the surface, for example, near the top of the midbrain or near the ependymal membrane of the midbrain. And for the cavernomas close to the fourth ventricle and third ventricle. For third ventricle cavernomas, we can easily access the cavernoma with frontal approach with a ventriculoscope. For the fourth ventricle, if the cavernoma is very close to the ependymal membrane of the fourth ventricle, we can consider to access the lesion through the foramen of Marchanti posteriorly with a ventriculoscope. But for the midbrain cavernoma, we can only access the lesion through the frontal horn and the foramen of Monroe and third ventricle and to the midbrain. And if it is necessary, we can use the rigid scope as well, combined with flexo scope to do the job. And navigation, intraoperative navigation and contact laser technique are essential for this pure ventriculoscopic resection of the cavernoma. Because if we use contact laser, you can use just like one instrument, which is a contact laser probe. One instrument has 2 functions. One is hemostasis or coagulation, as well as resection, because the laser probe can has a vaporize function to do the job, right? So it will save a lot of time and has very high efficiency. So we are still working on the improvement of the further modification of this technique, but we think it is promising in the future with improvement of the instruments and the scope. And I invite you guys to join us to do the same job or try to improve this technique together. Thank you very much.
Thank you. Thank you, Professor Chen, for this wonderful talk. It was indeed wonderful. So now I would like to invite Dr. Ashish to give comments. Please, Dr. Ashish.
Thank you, Dr. Ishu. Hi, Professor Chen. Excellent lecture. I think I've not seen a lot of intraventricular resections for cavernoma. But there are a lot of young neurosurgeons watching this webinar and are here as well. So I just wanted to ask, like in terms of indications, when you talk about risk of bleeding, what do you consider the risk of rehemorrhage? Like, because all cavernomas will have microbleedings within their capsules and they will be completely asymptomatic. So how do you differentiate and how you select your cases based on clinical symptoms or based on the kind of hemorrhage, whether it's within the capsule or it's a macro hemorrhage, neurological deficits? So if you can just guide us through some indications for these kind of surgeries.
Well, that's a great question. Thank you for asking. So as I have said in the introduction of my presentation, the brainstem cavernomas, if they have previous hemorrhage episode, they will have very high, over 30% of the chance to have the rebleeding. So, which means we should be more aggressive on this kind of case with a previous hemorrhage episode or history. So, so far we have performed 6 cases. All of them has got previous hemorrhage episode. So that's our indications. And personally, I do think that for the indication of the surgery for brainstem cavernomas, it is still controversial. So why it is controversial? So some group that thinks that if the patient got brainstem cavernomas and got only one bleeding episode, we should observe until the second episode of the bleeding and we perform the surgery. Why we have this kind of controversy? Because the risk of the microsurgery is quite high. So we are hesitant to access and to try to resect this cavernoma traditionally. But if we can develop some minimally invasive way to lower down the risk and to lower down the efforts that we need to do to resect the brainstem cavernoma, maybe in the future, the indication will change, right? For natural history, for example, the bleeding natural history, if our of the brainstem cavernoma natural history is at this level, if the microsurgical surgery risk is higher than the natural history, then we will hesitate to do the surgery, right? But if we can lower down the risk of the surgery with some minimally invasive technique here, which is lower than the natural history of the disease or the brainstem cavernoma, then maybe we will be more aggressive on this kind of lesion, right? So I do think the indication will change in the future with the development of the minimally invasive technique. But so far, we still want to stay at the safe side. So all the case we select into our study is the case which has previously hemorrhage episode, at least once. So in this case, because for brainstem cavernoma, we have the data that confirm that if we got more than one hemorrhage episode, they will got rebleeding rate as high as over 30%. So then we have a very reasonable indication to do the job, right? So that's our opinion. Thank you.
Thank you, Professor Chen. I'll also want to expand further on that. In terms of clinical symptoms, these patients, what were their symptoms like clinically?
Yes, that's another great question. So all these patients, you will notice all these patients got headache and got dizziness and also some cranial nerve deficit like double vision. And for the midbrain lesions, all of them has got hydrocephalus because the lesion blocked the aqueduct. And I forgot one indication that we should emphasize, that for midbrain cavernoma, if you want to perform the ventriculoscopic resection, you should select some cases with hydrocephalus, because in that case, the enlargement of the left ventricle will facilitate us to access the lesion with the ventriculoscope. Otherwise, if the patient got very narrow ventricle, you can never access the midbrain. But for the cavernomas located in the fourth ventricle, it doesn't matter. We just through the foramen of Machanti, you can passing through the foramen in a very, very narrow foramen. It doesn't matter. So that's symptoms of our cases. Thank you.
Essentially, they are more related to hydrocephalus. That's what I assume, because of the obstruction of the CSF outflow.
Yes.
I also wanted to ask, like in terms of those cavernomas which are coming from the floor of the fourth ventricle, they are like on the brainstem surface. Any cranial nerve deficits or any neurophysiological monitoring you do to make sure that there are no added cranial nerve deficits while resecting those tumors?
Yes, great question. So far, we have got only 2 cases for the cavernoma located in the fourth ventricle. All of them are located in the pons, and all of them during the surgery we routinely use the neurophysiological monitoring for this, mainly the facial nerve and the trigeminal nerve, and these 2 cases of the cavernoma located in the fourth ventricle case, they are all suffered from the headache and the dizziness. But previously, preoperatively, they do not have any deficit of the facial nerve or the trigeminal nerve or other cranial nerve, just headache and dizziness. So that's our cases. Thank you.
I consider that using navigation and most importantly laser, like I think that helps a lot in managing the hemostasis. Few last questions, like in terms of navigation, once you go into the ventricles, probably your navigation won't be too accurate, right? Like would you realize you cannot rely on navigation once the CSF comes out. So how do you, as soon as you get into the frontal horn, the navigation goes like?
Yes, that's a great question. So first, for brainstem, for example, fourth ventricle and cavernomas, the brain shift is not so significant. It's not as significant as the case in lateral ventricle, because the brainstem shifts a little bit less than the cerebral lobe, right? So the second is we use electromagnetic navigation with the endoscope, and which is we want to decrease the registration error of the navigation system, because for example, if we use a ventriculoscope, if you want to use optic navigation, we will apply the registration frame on the scope itself, and it then registers the scope with the navigation system. But this procedure will cause some error, distance error. And another problem is the optic navigation is not the tracking of the tip of the endoscope. So that's a problem. So we always try to avoid the use of the conventional optic navigation with the endoscope. We use electromagnetic navigation, which has a very thin probe, navigation probe with a diameter of only 1 millimeter, which can be inserted through the instrument channel of the ventriculoscope. And the electromagnetic navigation always tracks the tip of the probe, which is, in this case, the tip of the ventriculoscope. So in this case, first we track the tip of the endoscope directly. Second, for brainstem, especially pons or the fourth ventricle, which has a less brain shift distance than the cerebral lateral ventricle. So in this case, we think it is a little bit more precise than the conventional navigation in the lateral ventricle case, right? But still, we have to do the double check with the hemosiderin deposit at the ependymal membrane at the fourth ventricle, not completely rely on the navigation system. That's our trick. Thank you.
And are you doing endoscopic third ventriculostomy in all these cavernomas which are ventricles? Like because there was some hemorrhage, I was thinking like postoperative, postoperative shunt. All these 6 cases, anybody required post-op CSF diversion, or all of them got
Yes.
like?
Yes, that's a great question. We for those cases with cavernoma and hydrocephalus, we always perform ETV first, endoscopic third ventricular ostomy first, followed by the resection of the cavernoma. And not a single case has got hydrocephalus after the surgery and needs a shunt or any other procedure. So that's our result. It is reasonable because for the cavernoma block with hydrocephalus, usually they are blocking because they are blocking the opening of the aqueduct. So it's a kind of obstructive hydrocephalus. So for obstructive hydrocephalus, the ETV has a very high successful rate. Success rate can be as high as 95%. So this result can explain our data. Thank you.
Thank you so much. Excellent presentation and very good discussion. Thank you.
My pleasure.
Dr. Ben?
Yes, and thank you so much for Professor Chen. Very good to see you. And your presentation is an eye-opening presentation to me concerning the use of the ventriculoscope. And also with your technique with the navigation, and also you previously present the VR and the AR registration, which is also very good use of the technology. And congratulations to you and your team. Most of the points was raised by Professor Kuma, and I just have one question. It's about when we talk about the cavernoma. So I saw that you use the laser. So how, because sometimes we are concerned with there could be a DVA, the developmental venous anomaly attached to the cavernoma. But if I can see that sometimes maybe using the laser, you have to together with there be a problem to the
Can't hear you.
Sorry, can you hear me?
Yeah. After the DVA issue, I cannot hear you after that part.
I'm sorry. So because I'm thinking whether you could dissect and preserve the DVA with using the laser, because sometimes you might sometimes maybe just vaporize the whole thing and then take it out. So yeah, how could you preserve the DVA?
Yes. That's a great question. But for us, because our cases are still very limited, we only have 6 cases, and among them, there's only 1 case has possible DVA. This cavernoma was located in pons. So we usually will remove the lesion and leave the possible DVA just there and perform the hemostasis at the lesion bed and leave the DVA intact. So because we do not want to, make trouble with this, because the hemostasis in the ventriculoscope is very, very difficult. So we do not want to make trouble with the DVA. So so far we haven't got any worsened case with DVA problem. So, but as I said, our experiences are still limited. So that's why I call today's presentation only as a technical note. That's not a complete study. That's a technical note. Thank you.
I see. Thank you. Thank you so much for the report.
You're welcome.
Yeah, dear.
Yeah, hi. First of all, let me thank Prof. Xiaolei Chen for this wonderful presentation.
You're welcome.
We learned a lot. Thank you very much. 2 questions. What is the type of laser that you use? Is it a carbon dioxide laser or which type? And the second question is that the periaqueductal gray matter is one of the main thing which is responsible for consciousness. So when you're using the heat induced laser for resection of cavernomas near the periaqueductal gray matter, have you had any unwanted complications like patients not waking up from the surgery or something like that? Thank you very much.
So that's a great question. Thank you for asking. So the laser we use, please note the name is contact laser. Why it is contact? Actually, it's a semiconductor laser machine. And why it is called contact laser? Because the laser has a very, very superficial vaporized distance, which is 0.5 millimeter. It is very superficial. And I mean, the effect distance of the laser is very short. So only you contact to the target and you can perform the vaporize and the resection. So it is very safe and for neurosurgical use. We can never use a laser probe or laser machine used by the urologist. It's too strong. And so that's so-called the contact laser. With this laser, we have never got any unexpected complication or I mean, unexpected bleeding, intraoperative bleeding, and any surprise in this kind of in this study. Although we have only selected very limited cases for the brainstem cavernomas, but we have got over 500 cases experiences using contact laser for the ventriculoscopic procedure from 2015. So it is very safe. We have never got any very severe complications, except one case is by our colleague, not by our team, by our colleague, and he used a laser and got inserted too deep when he tried to do the ATV, and the laser perforated the P1 artery and got very severe bleeding intraoperatively. And however, fortunately, we got a hybrid operating room and we performed the DSA for this case and performed the embolization, intraoperative embolization for the P1 artery. and followed by the endoscopic evacuation of the intraventricular hematoma. And the patient got no serious neurological deficit after the surgery. So that's the only case with this contact laser probe, because the user or the neurosurgeon is not so familiar with this probe. Maybe that's the first case that he uses contact laser. So otherwise, for our team, we have never got any case and serious complication with this laser. So it's very safe.
Thank you very much.
You're welcome.
So are there any more questions for Professor Chen?
So I have one question.
Yeah,
You're welcome.
Thank you, Professor, for your excellent demonstration of these technically challenges cases. So my query is there any cutoff point for the size of the lesion, up to which you consider this technique?
Yes, that's a great question. Luckily, we got usually for the brainstem cavernomas, they're not big or giant lesion, right? I think everyone agree with that. Most of the brainstem cavernomas are small lesions, right?
Yes.
And we think that for pure ventriculoscopic resection, it is better to deal with those lesions with a small diameter, which is smaller than 2 centimeters. It's better, and the smaller the better.
Okay.
That's our principle. But maybe when we got better technique or better instrument, maybe we will challenge the bigger one. But I really doubt that if we can have any brainstem cavernoma bigger than 2 centimeters, it is very rare. Anyway, now the boundary was set at 2 centimeters. Thank you.
Oh, thank you, sir.
You're welcome.
Thank you, Professor Chen. Now we have one more question from Dr. Michael. Yeah, Dr. Michael, unmute yourself.
Hello, can you hear me?
Yeah.
Okay. Thank you, Prof. It was an excellent presentation. So my question is, do you use rigid or flexible endoscope? Is it possible to use flexible endoscope for the kind of procedures? And the second one is how the learning curve as compared to pure endoscopic tumor resection and other procedures specific to cavernoma resection. Thank you.
I didn't hear very clearly. So I guess your question is for the use of the flexoscope, right? Flexible endoscope, right?
He's asking for whether you use both kind of scope or not. I think you have already shown it. You use both scopes.
Yes. We for the case which at the locations that we cannot directly access with the rigid scope, we will combine the rigid scope with a flexible scope. So which part is at the lower part of the aqueduct, just like the case I showed you, the case 2. So the flexoscope will be inserted through the sheath of the rigid scope. And the contact laser probe will be inserted through the flexible channel of the flexible scope. That's a kind of, this kind of fashion. So to the use manipulation of the flexible scope is a little bit tricky than the rigid scope because you have to, because the flexible scope has the tip can be only tilted anteriorly and posteriorly, and for the left and right side, you need to rotate the scope itself. It's not like a rigid scope. You can just tilt the scope at every direction that you want. So in this case, for the flexible scope, you need to use thumb to do the manipulation with a hand grid, to do the manipulation of the tip of the flexible scope. And it's a little bit tricky. That you need another hand to insert the contact laser probe. It's a little bit more difficult. But I mean, for my fellow, I trained them for maybe usually 5 to 6 cases, and they will be very familiar with this flexible scope. So it is okay. I think, you know, we are neurosurgeons. We are smart guys, right? So it should not be a problem. Thank you.
Thank you.
Dr. Daton and Nita Quinn. Yeah, please unmute yourself.
Okay, I seek apology. This is my daughter's ID. My name is Niamot. I am now in Fujita Health University, Ventane. I'm a recent fellow. So my question is to Dr. Chen. What you have seen, it is very new to me, and it's very excellent cases there. So do you have any cases other than thalamic cavernoma you did with ventriculoscopy with laser? That's my question.
Yeah, that's a great question. So we use the contact laser for ventriculoscopic procedure a lot. So far we have got several hundreds of the experiences for the cases of the use of the contact laser. We use it from 2015, and the majority of the cases are the hydrocephalus, obstructive hydrocephalus. We use contact laser to do the ETV. And for small tumors or small lesions located intraventrically, we use contact laser to do the pure ventriculoscopic resection of the intraventricular tumors through a single burr hole. So if you are interested, I can share you with this kind of cases later in the future. I'm telling you that it is technically feasible, and it is very easy and straightforward. For example, for intraventricular small tumors with a diameter less than 2 centimeter, now we use contact laser to do the resection, pure complete resection. For example, for central neurocytoma, for subependymoma, this kind of thing, and for cavernomas, of course, for cavernomas, we use contact laser, and we also use posterior approach through a form of Marchanti with ventriculoscopic procedure to resect the small tumors located in the fourth ventricle. We use this to resect one ependymoma in the fourth ventricle, with contact laser. So it is very useful. We almost use it in every ventriculoscopic procedure now. Thank you.
Thank you.
Thank you, Dr. Chen. I am Dr. Jeremy. I'm also a Fujita fellow who just joined today. Just had a question. I have seen most of your cases, the cavernomas have actually gone through the ependymal surface. But sometimes you get those cavernomas that have not gone, they have bled probably once or twice, and they have not gone through that ependymal surface. So there's a layer of brain tissue between the ventricle and the cavernoma. I don't know if you have experience with such cases, and probably what would you do? I've seen you also have neuronavigation, so that can help you localize where the cavernoma is. But I don't know if you have experience with those ones that have not bled into the ventricle. There's a layer of brain tissue between the cavernoma and the ventricular surface. Thank you.
Well, that's a great question. We please note that in my presentation, when we talk about the indications, we emphasize that the lesion should be very close to the ependymal brain or the membrane or the floor of the fourth ventricle or near the surface of the midbrain. Because just like you said, if the lesion is deep-seated, there's a little bit more brain tissue or the ependymal membrane covered between the lesion and the scope, then we will not choose to do this kind of a surgical procedure with a ventriculoscopic procedure. I mean, for some deep-seated intrinsic brainstem cavernoma, we will choose the traditional or conventional microsurgical technique guided with a navigation system. So that's our selection bias or our opinion for this kind of case. So we use the pure endoscopic procedure, resection for the cavernoma, for those only very superficial or near the surface of the brainstem. But for other places, for example, for cerebral, we can, because it's not as eloquent as brainstem, right? So for this kind of part, for cerebral lobe, deep-seated cavernoma, we can directly use the ventricle with the navigation to insert the ventricle to the target zone and search the lesion and to do the resection with a single burr hole. That's another story. If you are interested, we can share you with our experience in the future. But it's not as eloquent as brainstem. So that's our opinion. Thank you.
Are there any more questions? So I have one comment for Professor Chen. You are a very happy guy and you answer every question very, very happily. I really like the way you answer and take the questions from everyone. You are always saying that's a great question. So it increases the audience to ask more and more questions.
Yeah, you're welcome. Thank you for your compliment.
Yeah, everybody must acquire this quality from you.
Thank you so much.
So, Professor, yeah, we have almost reached at the terminal part of our webinar, and we have new Fujita alumni, the new fellows, so who want to introduce. So I invite new fellows to introduce themselves. Please, Dr. Najmin, we can start from you.
Okay. Good evening, everyone. Now I am at Fujita Health University Hospital. I joined here and started my journey here from 22nd August. I am Assistant Professor of Neurosurgery, working in the Ibrahim Cardiac Hospital and Research Institute. Previously, I worked there as a registrar for 3 years, and my area of interest lies in skull-base and vascular surgery. That's why I'm here under Professor Kato. So as already the session seems to be a bit longer, I made a small PowerPoint presentation for my better introduction. If Professor Kato permits me, then I can share my screen.
Can you please share?
I am feeling, I am facing some difficulties, I think.
And read it.
Okay.
Okay. So everyone, I'm Dr. Nazmin Ahmed. I am a neurosurgeon from Bangladesh. This is my country. I born in Rangamati in 1986. This is the place where I born. And I have completed my post-graduation in neurosurgery in 2020 from Bangabandhu Sheikh Mujib Medical University there. And now I am working as assistant professor in Ibrahim Cardiac Hospital and Research Institute. So this is my department, my working manpower with my professor. I am there with my medical officer and some other staffs, working staffs. So this is my OT setup. Though all of the modern instruments and armamentarium are there, but we'll still lack neuromonitoring system. So big lacking. So these are dedicated. We have neuro ICU, neuro HDU, as well as a modern ward setup for my patients. And this is my classroom, so beautifully organized. And we have a small skill lab too, though it's not very well furnished, but though my residents are practice suturing here. These are my activities, some kind of activities in my department. We are doing all kind of surgeries, except we are still lacking of functional neurosurgery. We didn't start it yet. So these are some of the academic activities I have tried to show here. So our area of scope lies all kinds of subspecialty neurosurgery except for functional neurosurgery. So for refinement of myself, I have already taken part of different workshops in home and abroad, and also participated in some conference. Now came here for fellowship. These are some pictures of various cadaveric dissection. So after joining here, this is a beautiful picture with Professor Kato and her team. Dr. Niyamuti is also with me there, and on the left side, this is one of my still picture. So in Fujita Health University Hospital, I have some remarkable learning curves, some new things I came to learn here, that is some advanced imaging techniques like computational fluid dynamics analysis for aneurysm surgery, as well as reconstructive images, which are very helpful for surgical perspective and planning. And also I came to know some new tips and tricks, both in endoscopic procedure and microscopic procedure as well, and some innovative therapeutic approaches for neurointervention as well. So beside this, we both doctors regularly practice bypass surgery on silicone tubes. There's some pictures. And my professor also assigned me with research article. These are the topics I am now working on under him, that is evaluation of intracranial aneurysm wall by computational fluid dynamics. Another one is peer endoscopic microvascular decompression of the trigeminal neuralgia. So these are the previously published. I have already worked on some research articles and published some book chapters. My ongoing book chapters is now 6. And I have a great interest on my research. These are some illustrations. I have a very big fascinations to draw medical illustrations. My family. Thank you very much.
Thank you. Thank you, Dr. Najib. Next fellow is Dr. Nimit. Kindly introduce yourself.
So my screen is visible?
Yeah.
Oh, okay, thank you. So myself, my name is Sayeda Niyamati Ferdowsi. I am usually called as a Niyamat. So I am 30 years old, born in 1986. I'm a neurosurgeon, worked as a medical officer in Bangladesh. So this is my several school and colleges, and I have graduated from Chittagong Medical College. It is one of the largest division of Bangladesh in 2010. I have my post-graduation on 2020 from Dhaka Medical College Hospital, that is Master of Surgery in Neurosurgery. So I have now working at the National Institute of Neurosciences and Hospital. It is placed in Agargarh, Dhaka. This institute basically provide the neurological diseases. So there are two big departments, neurology and neurosurgery, and other auxiliary division here. So our academic activities started from very early in the morning. It is started from morning session and in every day, and we have combined seminar with neurology and neurosurgery in our Tuesday. We usually discuss about the clinical cases and research paper and article, and we usually present the journal clubs here also. As our neurosurgery department is divided into different subspecialty units, so we have also a small group discussion and meeting there also. So our field of works are usually clinical neurosurgery. We have 3 units that is dedicated for clinical neurosurgery. All these general neurosurgery are doing there. We have a pediatric neurosurgery unit. We have one neurospine unit and a neurovascular unit. We have one gamma knife surgery unit also, and we have functional neurosurgery and 2 trauma department also. So in our vascular activities, I am very privileged to show you that some of my cases that I have got opportunities to do this aneurysm cases. We have did usually more than 99% cases are ruptured aneurysm, because all of the patient came to our stroke unit. We have 100 bed state stroke unit. They screen out from the stroke unit, they send the patient to the microvascular surgery or for the endovascular procedure. As we have less supplied, government supplied coiling flow diverter and stent, that's why most of the patient came to our microvascular surgery. In our spine cases, we usually do all these spine cases. This is my some works in traumatic, degenerative, and pathological cases, and tumor also, and some congenital anomalies also. This is my some work. And we have also facilities to do some endoscopic PLID surgery, and we have minimum invasive surgery facilitated for obese patient, and we have also logistic for making them. And recently we have started scoliosis surgery correction. And this is some of the tumors that I had get opportunity to do in my unit. We have all kind of logistic like neuromonitoring, neuronavigation, endoscope, both spine and cranial. And we have 10 microscope from Kenovo, Pentero 900 to Leica, and some others. And we have facilities to do all facilities to do awake craniotomy. This is my practice of bypass surgery. I have started my practicing at home at chicken vessel 2.5 years back. Then I have did double barrel bypasses, and on the bottom of the right side, this is my patient, first patient of bypass surgery. This is the public institute, we have to do some peripheral nerve injuries too. This is median nerve injuries, and we have to do some brachial plexus injuries too. I usually try to attend all of the workshop, cadaveric workshop, and conferences that has been held in my country, and usually I like Japan, come to Japan. And I have also a big pleasure to share with you that I am usually I was hosting some social net in online television to make aware and keep the patient education of our neurosurgical diseases. And I have some chapters in this book that is in peer review. And now I am in Futita Health University. I am enlightened with Professor Yoko Kato. And my desire is to make myself more refined. And I want to learn more from Professor Yoko Kato and and her team. This is my family. And thank you very much.
Thank you, Dr. Niemet. Thank you very much. Now that the new fellows, they have been introduced, the webinar is now come to the end. And we have a 1 hour old fellow, Dr. Tushit Mewara. Tushit, are you there?
No issue. One more.
Yeah.
One more doctor from Kenya. He just arrived yesterday.
Dr. Jeremy.
Dr. Jeremy. Yeah, please.
Hello.
Hello.
Let me just share my screen.
Not now.
Okay, I hope you can see my screen.
Yeah.
Okay. Just an introduction. I've just arrived today in the morning. Yes. And all the way from Kenya. It was a 17-hour flight. But I'm happy I've arrived at Fujita, and Dr. Feduse and Dr. Nazbin have been really helpful in helping me to settle down. So this is just me. My name is Dr. Jeremiah Omoro. I'm 35 years old, born in 1989. And the hospital that I used to work for before I joined my residency is Kisii Level 5 Hospital. And this is just the flag of my country, Kenya. So as I presented, Kenya is a country in East Africa, one of the biggest countries around the East Africa region. It's bordered by Ethiopia, Somalia, Tanzania, and Uganda. And this is just the capital city is Nairobi. And where my hospital is, just closer to the western edge of the country, around the lake region. So that is where my hospital is. And the introduction, the country itself has 62 neurosurgeons. And so we've just graduated, we just finished our exams on Friday. And we graduated eight of us, but 5 of us are Kenyan and 2 of them are from the other countries. So we've just added to the pool of 62, we've added 5 more. So now we'll be 67 neurosurgeons. But you can see still our population of neurosurgeons to the population is still very low, with one neurosurgeon almost covering 1 million of the population. Our country itself is a low middle income country with a GDP of around 95.50 billion and a GDP per capita of 1,816 US dollars. So in my education, I studied my bachelor's degree from the University of Nairobi from the year 2007 to 2014. Then I proceeded on to do my 1-year full internship and then 2 years as a medical officer. Then I joined back for a master's program in 2009. And as I said, I just finished on Friday. So I've not even been able to go back to my hospital. So I just decided to just come to Fujita to learn more before I embark to go back to my county. So I'll be able to graduate in December of this year, and from then I'll be able to go back to my hospital. So this just shows my work experience from my internship, from my medical officer, then to residency, and now to be able to graduate and become a consultant at the end of the year. So this is just a picture of us as residents. the three of us to the far left of the screen, and the five to the far right of the screen. As I said, 4 of us will be Kenyans. There will be one guy going back to Cameroon, and 2 other guys going back to Tanzania. So we'll be adding 4 neurosurgeons to the pool of 62 neurosurgeons in the country. So just a photo we did just after finishing our last OSCE examination with a successful 100% pass rate for all the residents who sat for the exam. So this is the hospital I've been training at. Kenyatta National Hospital is the teaching and referral hospital in the country, receiving referrals all the way from East Africa as far as Central Africa. It has 1,800 bed capacity. The unit started in 1967, but the program, the Neurosurgery Masters of Medicine program, began in 2006. We've had persistent graduations from the year to 2011. The initial graduates were 2, but with the years, the residents have been increasing in numbers, and now we're actually graduating 8 to 9. The class that will be following me will have 7 residents who will also be graduating from the program. The hospital itself has a dedicated neurosurgery theater with the 24-hour neurotrauma theater and a critical care unit of 21 bed. That is the main critical care unit. But within the unit itself, we also have 5 bed capacity for specifically the neurosurgery residents. And this will be my hospital that I'll be going to at the end of my training at Fujita. It's a KC level 5 hospital. It's a regional hospital serving a population of around 2 million or 3 million population. It's a 700 bed capacity, and I'll be the first neurosurgeon who will be going to that hospital to cover the region. The ICU itself has a 5 bed capacity. Recently, I was there to just assess the facility, and there's still some challenges with the neurosurgical unit and the available facilities, but I'll be able to go back and try and mobilize what I'll be able to do to be able to cover and do some basic neurosurgical procedures. So this is just the hospital entrance. This is the emergency and care unit, and upstairs you see the theater unit. So you can see the close proximity between the casualty emergency and the theater unit. The ICU is also close by, just to the far right of the screen. That will be able to get the ICU center there with the 5 bed capacity. In terms of cases that we've been able to see, you've seen most of the spectrum of surgery, from cortical-based lesion like this huge parasagittal meningioma. We can see some pediatric cases like encephaloceles, and even some middle-age basilar invagination cases that we've been able to do. And that is also a baby who had a groin skull fracture. These are some of the cases we have seen. You can see even the infection rates like tuberculomas, that we'll be able to remove them successfully with the patients doing well postoperatively. And even huge posterior fossa tumors like this huge medulloblastoma in this 2-year-old female child. We also tend to get some neglected cases like this lady, who was a 35-year-old lady who had a huge giant frontonasal mucocele, that we were able to resect the lesion with good cosmetic and functional outcome for the lady. So this is just some of the cases you've seen. We also get to see some vascular cases and open microsurgical clipping. We've not been able to see any endovascular cases, but those are some of the cases that I really want to learn from, as I've just come to Fujita Hospital Bantane. My interests are in skull-based surgery and vascular endosurgery. I want to be able to learn and do the open as well as endovascular cases, and these are some of the things that I'll be able to take to my hospital. So in summary, that's what I had for the team today. I'd like any clarification and questions. Thank you.
Thank you, Dr. Jeremy. Thank you very much for the introduction. So, I think now the webinar is finished. Are there any more fellows? Yeah, Professor Yoko, please unmute yourself.
So maybe the 2 seat, you can give us one word. So one more fellow.
Tushit.
Yep. Hello, everyone. This was very nice seminar today. The topic Professor Chen told was, you can say, out of the box, not a regular neurosurgery. And all the methods he has shown here are almost, you can say, fantastic. Thank you, Professor Chen, for sharing this. And Dr. Maruf has also given a very, panoramic view of endoscopic neurosurgery, and especially that shoelace repair for the dura is very good to take home as a message. And I am very happy to be a part of this webinar today itself. Thank you very much.
Thank you, dear Tushit. Maybe hopefully we'll see you more and more, and in the
I will do that.
Seminar.
Yeah.
Tushit is a very busy man.
Yeah, it was a pleasure that he joined today out of those endovascular procedures.
Yes.
It is all because of Professor Kato.
Yeah.
I don't do that.
Professor Alberto met me last week in India. He came for the conference. It was a wonderful reunion. Then I was remembering our days in 2016 when we did fellowship under you. It was wonderful.
Yeah.
So any closing remarks, Professor?
Oh, thank you very much, especially Dr. Chen, Xiaolei Chen, till the
You're
end.
welcome.
So thank you
My
very
pleasure.
much. So I think his level is very high. So maybe I think we should visit his place and we can learn, or maybe some conference in between ACNS and also his place, I think. Because
Sure, no problem. My honor.
Since the alumni member is expanding more and more, so maybe you can assist or you can help each other, and also that we can have a more the good knowledge from the guest. So I think China is expanding very high speed, I think. So all the best in the future career. Thank you so much. Thanks.
We learn from you.
Oh, thanks. So anyway, maybe we can visit his place. I think it's worthwhile to see his surgery. You see.
Sure. So everybody is welcome to visit us in Beijing.
Yes. Beijing is not so far. Yeah,
Yes.
Thanks a lot. Thank you very much.
You're welcome.
Thank you, everyone. So I will say now, bye-bye. Arigato gozaimasu.
Bye-bye.
See you next
Thank you so much.
Bye.
Yeah, everybody.
See you next month.
Good night.